Diana empty table, empty Baja. Chief Ben Nadupeo, Million Abusa, Alabama, I want you and Larry. I don't need Pulare, Larry, I didn't. Pula, 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 Pula.
Let's clear the lobby. I've cleared the middle out. The academic procession is going to fire in any moment from now. Ladies and gentlemen, please rise as the academic procession files in.
the Deputy Vice Chancellor Academic, Registrar, Bursar, University Librarian, Provost of the College of Medicine and of Postgraduate College, 12th Vice Chancellor, Dean Faculty of Dentistry, Deans of other faculties and of students, Directors of institute and centers, Heads of departments, distinguished guests, ladies and gentlemen. The 607th University of Ibadan Inaugural Lecture will be delivered by Professor Folake Barakat Lawal of the Department of Periodontology and Community Dentistry on behalf of the Faculty of Dentistry. Folake Barakat Lawal was born into the family of Mr. and Mrs. M.A. Odu from Samojo, Yewa, Ogun State. She attended Orita Mefa Baptist Nursery and Primary School, Orita Mefa, and St. Anne's School, Molete, Ibadan. She gained admission to study dentistry at the University of Ibadan in 1995, graduating with a Bachelor of Dental Surgery degree 2003. She taught at the University College of Spirit, Ibadan. Between 2003 and 2004, and the National Youth Service Corps Score Scheme between February 2004 and February 2005 at the Dental Center of the Adeoyo Maternity Hospital, Imetu, Ibadan. She commenced her residency training in October 2006 in community dentistry at the University College Hospital, Ibadan. She completed the program and passed the final fellowship examinations of the West African College of Surgeons in April 2012 and the National Postgraduate Medical College of Nigeria in May 2012. She was appointed Lecturer 1 in the Department of Periodontology and Community Dentistry of the University of Ibadan on 18 July 2012. Promoted to the degree of Senior Lecturer in 2015 and Professor of Community Dentistry on 1 October 2020. Professor Lawal obtained a certificate in systematic reviews and meta-analysis from the University of Gothenburg, Sweden in March 2019. She was awarded the fellowship of the Consortium for Advanced Research Training in Africa, Qatar, for a PhD in community dentistry, which she completed in August 2021. Professor Folake Lawal is a fellow of the International College of Surgeons, a fellow of the International College of Dentists, and a fellow of the Nigerian Academy of Medicine. She has served the university in various capacities. She has been a member of committees at departmental, faculty, college, and university levels. She was a former sub-dean undergraduate in the Faculty of Dentistry, elected member, College Academic Board between 2016 and 2020, member, College of Medicine Research Grant Committee, and faculty representative, University Committee on Women Achievers of the University of Ibadan at 70 years, among others. She has served as the head of the Department of Periodontology and Community Dentistry since August 2023. Professor Lawal has served the University College Hospital as an honorary consultant, member or chairperson of and coordinator of programs outside the university. She's an examiner at the membership and fellowship levels of the West African College of Surgeons. She also examines at the Part 1 level of National Postgraduate Medical College of Nigeria. She was a visiting professor at the School of Dentistry, University of Minnesota, Minneapolis, USA, in 2024. She has served as external examiner to the University of Lagos, Bayero University, Kano, the Obafemi Awolowo University, Ile-Ife, and the University of the Gambia, Banjul, the Gambia. She has also served on the accreditation panels to various training institutions in Nigeria and Ghana. She was elected as the president of the Association for Dental Public Health Practitioners in Nigeria. Professor Folake Barakat Lawal has published over 100 peer-reviewed articles. And many other commissioned and non-commissioned academic writings. She has supervised 8 fellowship dissertations and is currently supervising 2 PhD candidates. She serves on the editorial boards of the African Journal of Medicine and Medical Sciences, the Journal of Evidence-Based Dental Practice, BMC Oral Health, and BMC Public Health. Folake Lawal is happily married to Taiwo Lawal, a professor of surgery in this university, and the current dean, Faculty of Clinical Sciences. They are blessed with 2 boys and 2 girls, and probably still counting. It is now my pleasure to invite Professor Folake Barakat Lawal to deliver a lecture titled From Schools to Glocal Communities, Impacting the Oral and General Health of Generations. Professor Lawal.
The Vice Chancellor, Deputy Vice Chancellor Administration, Deputy Vice Chancellor Academic, Deputy Vice Chancellor Research Innovation and Strategic Partnerships, Registrar, Bursar, University Librarian, Provost of the College of Medicine and of the Postgraduate College, Dean of the Faculty of Dentistry, Deans of other faculties and of the students, Directors of institutes and centers, Heads of departments, distinguished guests, ladies and gentlemen. I begin this lecture in the name of Allah, the most gracious, the most merciful, to whom all glory, honor, and adoration are due. I'm grateful to the management of the University of Ibadan, headed by the Vice Chancellor, Professor Kayode Adebowale, for the privilege to deliver the 607th Inaugural Lecture of our great university. I am also grateful to my Dean, Professor Bamidele Kolude, for nominating me. I am from the Community Dentistry Unit of the Department of Periodontology and Community Dentistry. This is the 15th inaugural lecture from the Faculty of Dentistry, the 5th from the Department of Periodontology and Community Dentistry, and the 3rd from the Specialty of Community Dentistry. The first lecture from the unit was delivered by Professor Gbemisola Oke in 2005, while the second lecture was delivered by Professor Juliana Taiwo in 2017. Today's lecture showcases the mentorship that has been received over the years from the first 2 lecturers and others within the department, and indeed the Faculty of Dentistry. Vice Chancellor, sir. The Community Dentistry Unit was established in the early 1980s by Professor Gbemisola Oke in the former Department of Preventive Dentistry. Community dentistry, also referred to as dental public health, is the science and practice of preventing oral diseases, promoting oral health, and improving the quality of life through the organized efforts of the society. The science of dental public health involves diagnosing population's oral health problems, establishing the causes and the effects, and planning effective solutions. The practice of dental public health is with implementing effective solutions to population's oral health and healthcare problems. The Community Dentistry Unit manages primary oral health care centers at Idiko, Igwara, and at Scholar Daisy Foundation Primary Health Care Center, Yemetu, Ibadan. The unit engages in outreach programs to different communities within and outside Ibadan. Choice of career. I must be grateful to the Almighty Allah who guided my parents to ensure that they pursued my admission into dentistry. Although it was Herculean then, as my admission letter to the University of Ibadan was nowhere to be found, and my father had to make numerous trips to the JAM headquarters in Lagos seeking the letter. Thank you, Father. His common saying was his children must go to school that he was unable to attend because there was no money for him to pursue the dream of being well educated. He always mentioned that he sponsored himself with the little he was able to make to attend the level of education he had with the support of his mother, who was a trader. I must also thank my mother, who was always there to encourage us when it looked as if the admission was hopeless. Alhamdulillah, here I am. I chose community dentistry as a specialty because my background taught me a lot about the community. I grew up in a tenement building where families from various social classes lived. I learned how myths, misconceptions, and beliefs got entrenched in daily living. Indeed, being raised by a village as it was then prepared me for work with the underserved, thus aligning with the scope of community dentistry. There are many subspecialties of dental public health, and my research As we're centered on school oral health promotion and the impact of oral health on the quality of life, I have adapted global best practices to solve local challenges in oral health promotion, paying attention to cultural, economic, and social realities. I have developed solutions that have contributed to global oral health goals. Thus, my work has impacted the inhabitants of local communities. Think globally and act locally. That is Glocal. My research focus was greatly influenced by my mother, a teacher, and my father, a custodian of books. I grew up in teachers' community. If you did, you have first-hand experience like I did. My first research work was my undergraduate project, which was conducted among inhabitants of Aberdeen community with my group mates. We found that poor oral health practices existed amongst them. Based on these findings, my Master of Dental Surgery research work investigated the oral health practices of residents of Idikon and underserved community. Within that community, I also found that poor oral health practices existed among the residents. The findings from the master's research project provided evidence for the need to assess how oral health impacts the daily activities of individuals. Thus, my fellowship projects focused on validating and assessing the impact of oral health on the quality of life. The research provided baseline data, diagnosing population oral health problems, establishing the causes and effects, as well as impact of oral problems on the quality of life. I pursued solutions in the form of interventions to the problems that have been identified, and these were targeted as my PhD research projects. My postdoctoral projects continued with the interventions, focusing on the alternative solutions to population oral health problems in the face of brain drain. Vice Chancellor, sir. My research in dental public health has taken me from my birthplace in a community of teachers to homes and schools from Ibadan to many areas of Nigeria and beyond, working with pupils, adolescents, adults, and the elderly. Hence the title of today's inaugural lecture, From Schools to Local Communities, Impacting the Oral and General Health of Generations. I will now present a synopsis of my research activities over the years. Oral health. The definitions of health and oral health have evolved over the years. The current definition of oral health sees oral health as integral to overall health, intertwined with daily living to encompass physical, biological, social, psychological, and functional domains of life. Therefore, the quest of a dental public health professional in ensuring optimal oral health cannot be complete until promotion of oral and general health is achieved hand in hand. Oral diseases constitute one of the leading non-communicable diseases affecting 3.69 billion people globally. The two most common oral diseases affecting mankind are periodontal diseases and dental caries. Periodontal diseases affect the gums and teeth supporting tissues and are characterized by bleeding, painful and swollen gums, shaking teeth, and eventual removal of the affected teeth. Dental caries is also known as tooth decay or hole in a tooth. Both are highly preventable by simple measures such as self-oral care. It is worthy of note that the diseases have been associated with high morbidity and mortality in low-resource settings. Vice Chancellor, sir. Untreated dental caries of permanent teeth has been documented as the most common condition of the 371 diseases and injuries that were studied in the global burden of diseases in 2021. Oral diseases are of public health concern because they have grievous consequences on overall health and well-being. Oral health status. We diagnose populations' oral health problems by assessing their oral health status. We assess the prevalence of dental caries among 1,286 children aged 6 to 15 years in Ibadan. The results show that 10% had untreated dental caries, and the number of carious teeth ranged from 1 to 9 per child. 1/5 were experiencing pain from the carious teeth at the time of the study. Among female adults, we observed that 25% had experienced dental caries, and extraction of the teeth was the dominant treatment received prior to the study. 10% had painful teeth. which buttressed the fact that many with oral problems did not seek dental care until complications arose and the teeth could no longer be salvaged. In the rural population, 32.4% of adults and 31.9% of the elders had dental caries. The prevalence of periodontal diseases is generally high among the populace. In a study conducted among adolescents in Ibadan, 73% had periodontal disease, with gingivitis being the commonest type reported. In the rural communities, we reported a prevalence of 54% among adults and severe forms of the disease, such as chronic periodontitis, which is characterized by destruction of alveolar bone and other supporting tissues, resulting in loosening of the tooth, was observed among the elderly individuals. We found that 46% of elders had experienced self-exfoliation, that is, removal of tooth by itself. 44% had mobile teeth and 96% had poor oral hygiene. Vice Chancellor, sir, we were able to establish that dental caries affected both the young and the old, and many have untreated decayed teeth with pain, thus a need for intervention. It is worthy of note that although the common rule of the term was that dental caries is a disease of the young and periodontal disease that of the older age groups, our findings proved otherwise. Consequences of oral diseases. If oral diseases remain untreated, such as a mobile tooth, the tooth could exfoliate on its own. Infection from decayed teeth could spread to adjoining areas of the mouth, jaw, face, chest, and the entire body. The affected individual could have abscesses, cellulitis, respiratory difficulties, and so on. And in such instances, treatment modalities could involve removal of the source of the infection, the tooth. Edentulism. Removal of teeth or tooth loss in any form is known as edentulism, which can lead to malnutrition and suppression of immunity. We were able to establish that tooth loss could result from dental caries and periodontal diseases. Our research showed that the prevalence of missing teeth is high among adults in the rural community. 44% had at least a missing tooth, while a prevalence of 51% was reported among the elderly population. Two were completely edentulous, and only 4% of the elders had their missing teeth replaced with partial dentures. In a suburban region in Ibadan, 48% of the elders had at least a missing tooth, and 7% had replaced their teeth with acrylic partial dentures. The finding confirms that those living in the urban or suburban regions are more likely to seek help for their oral problems than those in the rural regions. Alas, the sparsity of dental professionals in such regions may also be responsible for this. The poor oral health status that was observed from our studies illuminated the path for further research to investigate the possible factors that could be responsible for poor oral health findings. Factors associated with oral conditions. Different studies have reported the role of determinants such as the biological, social, and environmental factors that dictate the health of individuals and are interwoven. We conducted studies to determine the biological determinants influencing oral health. Younger female participants aged 44 years and below had more untreated decayed teeth. In another study, individuals in older age groups were reported to have more mobile teeth and other forms of periodontal diseases. We investigated the social determinants of health, which are non-medical factors influencing health. These factors include health-related knowledge, attitude, behavior, gender, lifestyle, and so on. Oral health knowledge, attitude, and practices. Vice Chancellor, sir. From our research, we reported that oral health knowledge was poor amongst children, adults, and elders in our communities. We documented that 2,096, representing 99% of adolescents in selected public schools in Ibadan, had an oral health knowledge score that was less than 50%. Very few knew the causes of common oral diseases. Students in the younger age group, those whose parents belong to higher social classes, those who have previously received oral health education, or previously exposed to dental consultation, and those with healthy periodontium were more likely to be knowledgeable about oral health. Poor attitude towards oral health has been reported in our various studies. In a study, younger adolescents and those who have participated in previous oral health education had better attitudes towards oral health. Our findings amongst children and adults mirror those of adolescents, suggesting low level of oral health awareness generally. Teeth cleaning. The primary cause of many oral problems is bacterial plaque. These are deposits that contain bacteria and debris formed on teeth. Good oral health practice to remove bacterial plaque from the oral cavity by effective cleaning of all the teeth surfaces is one of the modes of preventing oral diseases. It was therefore important to investigate the oral health practices of the populace among children in a rural community. 76% clean their teeth once daily, 6% twice or more often daily, and 18% did not clean their teeth or cleaned irregularly. Most adolescents in our studies use toothpaste to clean their teeth, and this could have accounted for the lower prevalence of dental caries reported amongst them, despite consumption of caries causing diet. In a community house-to-house survey in Ibadan, we observed that toothbrush was used to clean the teeth by almost half of the adult population. Findings among 357 elderly inhabitants in the rural communities of Idere and Igwora differ from what was reported in the urban settings, where it was observed that 55% used chewing sticks as the main tooth cleaning aid. Two surfaces cleaned. Another of our studies showed that 19% cleaned all the teeth surfaces, interdentally as well as the tongue. This reflects the true picture of how we clean our teeth, as only a few of us clean all the teeth surfaces, and it is not impossible that it could be a reason why preventable oral conditions are prevalent. The low proportion of participants cleaning the interdental areas in the mouth guided our studies on interdental cleaning. Interdental areas are located in between surfaces of the teeth. They have been shown to be a major source of dental problems and often neglected area during teeth cleaning due to their inaccessibility by toothbrushes or chewing sticks. Interdental cleaning requires conscious effort and use of specially designed tools. We explored the interdental practices among the populace to inform the design of our oral health education protocol. The results of the survey showed that only 23% practiced interdental cleaning. Surprisingly, 2 patients used blade and broomstick that can harm the tissues in the mouth. In that study, the main reason given for not cleaning the interdental areas was lack of knowledge, inadequate teeth cleaning, and oral conditions. Accumulation of dental plaque and its solidified form called calculus in the mouth, a condition termed as poor oral hygiene, has been associated with common oral diseases and conditions. It was confirmed by our findings. Among the elders in the rural communities, those with mobile or decayed teeth, those with incomplete dentition, or cleaned less frequently had poorer oral hygiene. Thus, we ensure that demonstration of teeth cleaning to our audience continue to form a basic aspect of our health education at all programs. We recommend regular twice daily cleaning of the teeth after meals, using medium texture toothbrush or chewing stick, pea-sized fluoride containing toothpaste, and flossing of the teeth. Our tooth cleaning agents should be kept away from rodents and toilets and should not be shared with anyone. We are to minimize sugary foods, drink a lot of water, eat balanced diet, and consult with the dentist every 6 months. Utilization of dental services. In developing countries, access to oral health care is a significant public health problem, albeit there are efforts by the public health team to ensure equity in access to care. We continue with our quest to understand if proximity to a dental clinic will influence dental visits. Among the inhabitants of the Deacon community, where the primary oral health care center was located, we found that 40% had been to a dental center and all went there because of toothache. Our findings showed that presence of a dental clinic within one's vicinity does not necessarily translate to visiting the center. In another study, we reported that 34% of elders in the rural communities had consulted a dentist previously, and pain was the main reason in 98% for doing so. Only 2 elders consulted the dentist for routine dental checkup. The main reason provided for not consulting the dentist by the majority was that there was no problem with them, as tooth problems and eventual loss occur with aging. This was mentioned by 76%. Our findings further confirmed that in our environment, consultation with the dentist is problem-driven. Vice Chancellor, sir, Our studies showed a very high prevalence of oral disease in our environment, and many individuals have unmet dental needs as they live with untreated oral diseases. We wonder then that probably oral disease does not have any effect on the quality of life of people, as reported from developed nations. However, we are limited in making the conclusion then as a subjective assessment of oral health tools were sparingly used and the oral health related quality of life tools are not be validated in our environment. Therefore, I went ahead to validate the tools and translated them to our local language to adapt the tools for our environment and to understand better how oral diseases affect the quality of life of our people. Oral health related quality of life. My work on quality of life has revolved around how the state of the mouth and teeth affects enjoying or denial of enjoying life to the fullest, such as the effects on eating, talking, sleeping, socializing, and so on. I worked on the Yoruba and English versions of the oral health related quality of life measures for children, adults, and the elderly for use in the Yoruba populace and English speaking Nigerians. I adapted and validated the commonly used tools such as Child Oral Impact on Daily Performance, Child Oral Health Impact Profile Short Form 19, Oral Health Impact Profile 14, and Oral Health Impact Profile 5 amongst children. Among adults and elders, I validated the oral impact on daily performance, oral health impact profile 14, oral health impact profile 5, and the geriatric oral health assessment index. The oral health related quality of life tools exhibited good psychometric properties with Cronbach alpha values greater than 0.7 and excellent validity. Impact of oral health on quality of life. Validation of the oral health related quality of life tools enable the assessment of how oral health impacts the quality of life among students that we studied. Oral health impacted the quality of life of at least 21% to as high as 94%. We found that oral habits such as thumb, lip, tongue sucking, and so on negatively impacted the quality of life of adolescents. Those who sucked their thumbs experienced painful aching in the mouth, were uncomfortable about the appearance of their teeth, felt that there had been less flavor in their food and a change in taste of food. Lip sucking was associated with problems with chewing food, while grinding of teeth together was associated with painful aching in their mouth. Thus, we incorporated education on oral habits and its prevention as part of our oral health education. In another study, we found that oral hygiene habits impacted the quality of life of adolescents attending selected senior secondary schools in Ibadan. The results revealed that those who cleaned their teeth at least twice daily were likely to have better quality of life, surprisingly. Those who cleaned interdentally had worse oral health related quality of life. The negative impact of interdental cleaning on quality of life could have resulted from inappropriately carrying out interdental cleaning or use of harmful materials for the cleaning that led to injuries to the gums and other teeth supporting structures. Thus, we continue to emphasize the importance of correct practice of interdental cleaning, other teeth cleaning procedures, and their demonstration during our oral health education programs. Amongst adult patients, 72 to 83% reported an impact of oral condition on their quality of life, painful aching in the mouth, and difficulty with eating, sleeping, and cleaning teeth were the four most reported activities impacted by oral health. Vice Chancellor, sir, I also investigated the impact of oral health on school teachers and found that untreated dental caries significantly impacted their quality of life. Thus, we concluded that untreated dental caries and periodontal diseases have significant impact on the quality of life of Nigerians. We therefore instituted interventions targeted at various levels of prevention of oral diseases and ultimately promotion of oral health. Interventions in schools. The school is an important avenue where knowledge, attitude, and practices can be imparted to an individual early in life through primary and secondary schools and subsequently entrenched in tertiary institutions. The school teachers teach the whole family and not just the pupil. They know the family and help to make the child grow without deficiencies when the teachers understand the background of the pupil They rarely ran to solve so many problems, thus building a healthy child. In the schools, many are with unmet dental needs, and we found children with oral abscesses. Some were unable to come to school because of teeth problems, although we asked them to come for treatment at the dental clinic, and we were ready to pay for such treatments. Many did not show up. We investigated why and found that some did not even have transport fare. School Oral Health Promotion Program, Vice Chancellor, sir. The School Oral Health Promotion Program focuses on educating the pupils, students, teachers, and stakeholders about oral health. It involves screening for oral conditions, appropriate enlightenment on prevention, treatment options, plans for sustainability, monitoring, and evaluation. Other activities depending on the age of our audience include education on lifestyles, screening exercises for blood pressure, blood glucose levels, and so on, and appropriate referrals. We have conducted over 2,000 oral health education programs at private or government-owned schools involving primary, secondary, and tertiary institutions. Over 100,000 pupils, students, teachers, and stakeholders have benefited from such programs organized by our units. Although some of the schools invited the team for oral health education, over 90% were initiated by our team. Some of the challenges documented included inadequate oral examination materials and oral health education aids, such as posters, handbills, and leaflets. Support subsequently came from the Consortium for Advanced Research Training in Africa, CARTA, who funded my PhD research. The CARTA Re-Entry Grant, TED Fund, and other funding agencies. My research projects have made available oral health promotional materials used by the schools to date. Also, the students have received free toothbrushes and toothpaste in addition to free treatment. I must say that I received numerous calls from parents, teachers, and well-wishers about the initiative, which brought smiles to the faces of students with toothache, students with missing anterior teeth who received dentures, students with poor oral hygiene that we did scaling and polishing for, and who were able to smile afterwards. I must say a big thank you to CARTA. Intervention among teachers. We conducted a study on the role of teachers in school oral health education. Over 90% of the teachers believe that they should play major roles in promoting oral health in schools. Despite the great motivation for involvement, glaring deficits were observed in their oral health knowledge, attitude, and practices, hence the need for training of the teachers. With funding from MacArthur Foundation, a training workshop was organized for 40 school teachers at Erua in Oyo State. There was improvement in the oral health knowledge of the teachers that participated in the workshop. Thus, our research demonstrated the utility of teachers being change agents in school oral health promotion. Furthermore, oral health promotion in schools goes beyond oral health education. Hence, there is a need to create health promoting schools. Strategies in oral health promotion. Vice Chancellor, sir. I had established the premises for addressing the high unmet dental needs of students through school oral health promotion programs. I decided to explore the visibility of engaging non-dentists such as peers and teachers in the programs. I utilized a sequential mixed method design to evaluate the effectiveness of school oral health promotion programs conducted by peers, dentists, and teachers among adolescents in Ibadan, Nigeria. The first phase of the study involved the qualitative design, and the second phase involved the cluster randomized control study of 1,800 students that were selected from 4 local government areas of Ibadan metropolis. The 4 local government areas were randomized into the 3 intervention arms of peer-led, dentist-led, and teacher-led resource persons and a control arm. The dentist-led oral health promotion strategy demonstrated the greatest effectiveness in improving oral health knowledge, attitude, practices, oral health-related quality of life, and oral health status of the students. However, following training by community dentists, the peer-led and teacher-led interventions produce comparable outcomes. They may, thus, serve as effective adjuncts or viable alternatives to dentist-led approaches in school oral health promotion programs, thereby further contributing to a reduction in the burden of unmet dental needs. Dispelling misconceptions. Vice Chancellor, sir. We undertook a lot of research in rural communities and found many myths and misconceptions. There were erroneous beliefs that teething causes fever, diarrhea, and other diseases. Also, some children erupted the upper teeth before the lower ones, and their families were stigmatized as a result. We found that the strong beliefs that such children and their families were cursed, among other beliefs, were deeply entrenched in both the urban and the rural communities. Also, we observed in rural communities there was sparsity of oral health data to inform interventions. We trained our students to conduct researches in the communities, from situation analysis to feedback, a form of research to policy initiative. After each research project, dissemination of information was conducted among the major stakeholders in the communities, teaching our students as well as to provide evidence for policy enactment in the communities. I must say that the efforts of the dental team have been worthwhile in changing some myths and misconceptions. However, challenging is the grossly inadequate number of dental and paradental personnel, making wide coverage difficult. This led to exploration of ways of mitigating this problem. Thus, we went ahead to develop some videos to correct misconceptions about natal and neonatal teeth and the teething process. The videos were found to be effective in changing the perceptions of the inhabitants of these communities about the misconceptions. With the successes reported in the rural communities, we advanced the use of the videos on oral health education to urban communities and to schools as part of school oral health promotion programs. School oral health promotion programs to help video. Based on the successful outcome of alternate strategies to dentist-led school oral health promotion on one hand, and the worsening effects of migration on availability of community dentistry, personnel to train the teachers and students on the other hand, I ventured into the use of pre-recorded videos. The pre-recorded videos can be used to complement the available specialists in training the teachers and students, thus ensuring sustainability of teacher-led and peer-led oral health promotion strategies. Under the umbrella of the SOHEB, I assembled a team of experts on the development of videos in 3 languages of English, Yoruba, and Pidgin, incorporating various steps, validated the videos, and utilized qualitative research and feedback to ascertain the effectiveness. From the focus group discussion, some said, and I quote, "The video was well composed and arranged. Presentation cuts across ages and the message was clearly explained. It is highly educative and informative," end of quote. Global impact. The description of how oral health impacts the daily activities of the populace led to my collaboration in a multi-country study led by Professor Mike John, and I was the African regional representative. The study was on dental patient-reported outcomes across the WHO regions. The study was designed to evaluate if the reasons why patients visit the dentist can fit the 4 oral health-related dimensions of oral function, orofacial pain, orofacial appearance, and psychosocial impact. The study provided evidence that focusing efforts on the 4 dimensions will lead to research that prioritizes problems that are of utmost concern to dental patients, oral health, and general health. Vice Chancellor, sir. Oral diseases often erode underlying systemic diseases, such as the link between periodontal diseases and hypertension, cerebrovascular disease, diabetes, mellitus, and dementia, and respiratory diseases. We explore the relationship between oral health, social and mental health using a qualitative design with focus group discussions conducted among 120 adolescents in Ibadan. The result of the study showed that although some adolescents perceived oral health as important, some others believed that oral health was inconsequential. Some of the adolescents considered oral health as integral to general health based on the important roles of eating and communication, which have effects on survival and social networking. For instance, one of the males said, and I quote, "It is so important to me because I know fully well that I am a man. You know, as a man, I have to toast girls. Bad results when talking if the teeth are not clean," end of quote. In another study, we evaluated the oral health awareness, practice, and status of 143 patients living with diabetes mellitus. We found that only a quarter knew that diabetes could worsen their oral health status, and barely 2% was conversant with the link between diabetes and oral health. When we examined their oral cavity, none of the patients had healthy gum. Oral healthcare information. Following the findings of poor oral awareness in some of the studies, we explored sources of oral healthcare information among 292 patients at the dental center. The study showed the overt reliance on dental patient professionals for oral healthcare information, with mass media and other sources barely accounting for 8% of the information. In our various outreaches And community oral health engagement. It is not unusual to see a high proportion of attendees needing referral for dental treatment. They are referred to a primary oral health care center if there is one near them, and to the dental center of the usage if they do not have one close to them, or if the cases require specialist care. The dental center has specialists in all dental disciplines. We evaluated the waiting time experience of 266 patients. Most patients were seen within an hour at the primary oral health care center, unlike what obtained at the dental center. The patients offer suggestions to reduce the waiting time, largely to employ more dentists and expand the facilities for treatment of patients. Indeed, there is a need to expand the dental center to align with the suggestions of the patients involved in the study. The dental consulting rooms at the Deacon Primary Health Care Center have been expanded based on the recommendations. We have also, in collaboration with the Department of Community Medicine, extended primary oral health care service to the Kolada IC Foundation Primary Health Care Center, Yemetu. Integration of oral health care services into primary health care. Professor Folake in 1988 established the first primary oral health care center in Nigeria. In furtherance of the innovation that had been made by Professor Oke, and with funding from Colgate, Palmolive, and the National Dental Association Foundation, USA, we developed a project, OHENCHU, Oral Health Education for Nurses and Community Health Workers. The multi-center project was conducted at Ibadan, Kano, and Lagos. The training positively influenced the knowledge, confidence, and referral ability of the primary health care workers. There was significant improvement in the knowledge and attitude scores of the primary health care workers in the intervention compared to the control group. The study confirmed the potential of the modularized training to enhance the oral health promotion capacity of primary health care workers and the need for incorporation into the national health policy as it pertains to primary health care services. Challenges. The journey of preventing oral diseases in the community is not an easy one. I must say, I had to go back home to change clothes when some students fighting in a school poured water on me. What about delayed approval? Waiting and waiting. In terms of transportation, we faced inaccessible roads, vehicular breakdowns, unfamiliar terrains, and so on. I've also faced challenges of lack of funds. I would like to say a big thank you to my mentors and teachers, as well as all the members of my team in the journey from the schools to the Glocal community. Conclusion. Vice Chancellor, sir. Over the course of last hour, I have presented an overview of my research activities. Our research indicated that poor oral health exists in our environment with dental caries and periodontal diseases being prevalent. The prevalence of dental caries was 10% among 6 to 15-year-olds, 5% in adolescents, 25% to female adults, 32% in rural adults, and the elderly. Early treatment was also not sought, allowing complications to set in. Periodontal disease was highly prevalent amongst children, adults, and elders, with proportions ranging from 53.9% to 100% in various subpopulations. Most of our study subjects require simple oral hygiene measures which are readily available in our environment. Consulting the dentist for routine dental checkup was not commonly practiced. The norm was to see myriads of consequences of oral disease and a very poor awareness of dental treatment to ameliorate the complications, such as the use of dental implants. Oral diseases severely impacted the quality of life of patients, pupils, students, adults, and the elderly. The care of the teeth was largely suboptimal, with poor awareness, attitude, and practices relating to oral hygiene. Most individuals were not conversant with the prescribed technique of toothbrushing. We documented poor oral health knowledge, attitude, and practices among pupils and students, but more importantly, instituted strategies that resulted in measurable improvements in the oral health status and quality of life of pupils and students in our various school oral health promotion programs. We also established the effectiveness of oral health education conducted by teachers and peers trained using audiovisual materials that we produced. I validated various tools to measure the oral health impact, oral health related quality of life of our population, and established acceptable psychometric properties, thus opening the door for their use. Recommendation. It is a great honor to make the following recommendations. School oral health promotion programs should be formalized across the country. There should be at least one school-based dental clinic in each local government area. The curriculum for the training of teachers should be revised to include basic oral health education. Primary healthcare workers can be used to bridge the gap in unmet oral health needs by incorporating oral healthcare into their work with supervision from a dental public health practitioner. The audiovisual aids and videos that we develop should be made widely available for oral health promotion. Mobile dental care services should be made available to underserved areas. Dental patient reported outcomes and other subjective assessment tools should be used to complement clinical care of dental patients. The federal government should consider building a larger, more comprehensive dental center for the UI and UCA to fulfill the mandate of research, training, and service provision. Acknowledgements. All praises are due to Almighty Allah, the most gracious, the most merciful, for his grace and his benevolence and for his manifestation in our lives. I thank Almighty Allah for the delivery of this lecture and for the successful conduct of all activities that served as resources for this lecture. For I can certainly answer the question often repeated in chapter 55 of the Holy Quran. Thus, which of the favors of our Lord shall we deny? I can boldly respond, none at all. Firstly, I wish to appreciate everyone who has attended this lecture, both in person and virtually. I also thank everyone who has contributed to the organization. I thank my parents for the upbringing and for laying a solid foundation for me to build upon. I appreciate my parents-in-law for their love for having me as their daughter. I appreciate my siblings, Biola, Lara, Lolade, and Ayobami, and I thank them for all they have done over the years. I thank Olade Abdugani, Latif Abanigo, and Yetude Udu. I thank the Lawals for their love and support always. Olori Ebi and Mommy Muiz, thank you very much. My gratitude goes to the Vice Chancellor, Professor Kaide Adebawale, and all members of management. I appreciate the Deputy Vice Chancellor, Academic Professor Juwan Rotiba. I thank the Provost, Professor Temidayo Ogundiran, and members of the management of the college. I'm grateful to the CMD, Professor J.C. Altegbaya management staff. Special appreciation goes to Professor Akinyinka Omigod for the tremendous support over the years. I believe that we have made you proud with one of the first inaugural lectures from Carter graduates in Nigeria. I'm grateful to the immediate past provost, Professor Olayinka Omigodun, Professor Gbemisola Oke, my academic mother, a woman of substance, amazing Amazon. Thank you for providing the ladder that I used to climb. My mentors and teachers, Professors Mudupiola Rowojolu, Juliana Taiwo, and Elizabeth Dosumu. You have been the pillars that held the house in place. Thank you for your tutelage, training, and mentoring. I appreciate the support of the staff of the Department of Periodontology and Community Dentistry, Professor Ibiyemi, Dr. Sokweodu, Osudedeke and Fabule, resident doctors, house officers, nurses, therapists, DSTs, health assistants, and all administrative staff. I have enjoyed the cooperation of members of the Faculty of Dentistry and the entire dentistry community. Some of them were also my teachers. I thank Professors Oluwole Dosunu, Fashola, Denloye, Kolude, Bankole, and Okojen. My appreciation also goes to the faculty officer and other staff of the faculty. I appreciate the support of the faculty's inaugural lecture committee under the able leadership of Dr. Amidu Sulaiman. My gratitude goes to the Carter family all over the world. I must appreciate the support I've received from my team at the University of Minnesota, led by Professor Mike John, and including Kathleen, Apana, Bill Gates, Dana, and Nicole. I thank Maisa Omara. The Mental Health and Wellness Study Group is appreciated. Professor Lubumi Bankole has been a great research collaborator. I thank you, ma'am. I appreciate Diola Abdul Salam along with Dr. Abbas Abdul Salam. I thank my Metiton collaborator, Dr. Abimbola Oladayo, and the members of the OHNTU project team, my former resident and mentees. Brigadier General Igbineweka, Dr. Safolabi Akiloye Idiga, and others are appreciated. I belong to the UIBDS class of 2003, and it has been a jolly good drive with you over the years. Ronke, Lola Bimbo, Timothy Jamila, and others. I am also a proud member of the Pouch 98. Thank you all. The UI MBBS BDS class of 2000 has shown me love because I married from that class. I thank Ansebe. I am indebted to the forerunners of community dentistry, Professor Jeboda Ogunbodede, Okeshofola Uti Adedigba, and others, as well as the executive and all members of the Association for Dental Public Care Practitioners in Nigeria. I appreciate all the funders of my work. My students have been a source of joy through different classes that journeyed with us in community dentistry. I thank all my teachers in primary school, secondary school, and at the University of Ibadan. I use as focal persons Professor Waifo Shokunbi Odolawurala Shokunbi Bakari and Raji. I must acknowledge Dr. Bode Falomo, my uncle, Professor Babatunde Salako, and his amiable wife, Alhaji Abiola Salako, have been there over the years. I appreciate Professor Layushi to senior colleagues and colleagues of my husband in surgery. I thank other members of the College of Medicine and UCH family. Department of Community Medicine appreciated Professor Priska Adejumo, our MD, and TTTVME, and others from Ogun West. Thank you. Vice Chancellor Tayo Lasisi, my dearest friend since our days as students, our Vice Chancellor, Professor Akim Lasisi, I thank you. Auntie Laide, you have been more than a peer mentee. You are a part of our family. My immense gratitude goes to the Muslim community of you and the UCH. Your spiritual support and fellowship have been worthwhile. Jazakumullah khairan. Special mention was made of the Motoshos, Morasin Belos, Baloguns, Babasonyas, Rajis, Tunji Lawaz, Adede Jimons, and the MSN Swine family. I thank Professor Wasio Adeyemo, CMD Loaf. I thank various Oyo State Commissioners for Education, members of the SUBEB, and all ministry officials. I'm grateful to the LOC for this lecture. I appreciate Mr. Olatunji Oladejo Abibulai Oladejo. I dedicate this lecture to all teachers, pupils, and students in primary and secondary schools in Oyo State, and all the numerous participants in my research activities. Akima, Nobil, Najib, and Amida, I love you all. I must thank you for the understanding and your cooperation. I thank you for your contributions to some of my research efforts. My husband, my team, èjìrí ará àṣokùn wíníwíní lójú orogún èjìwọ̀rọ̀ lójú ìyẹ́ ẹ̀. Where do I start from? Is it the fact that every single research proposal and publication of mine was reviewed by you, some through multiple editorials and inputs? Is it the work that you put in for this lecture, the book, the slides, the rehearsals, and everything else? According to the Holy Quran in chapter 30, verse 21, and of the sciences I created for you from yourselves, mates that you may find tranquility in them, and he placed between you affection and mercy. Indeed, that's a sign for a people who give thought. The verse sums up what you have been to me. Thank you for everything. Olowo ori mi, Hadi ori mi, my partner, my companion, he my love. I love you. Alhamdulillah. Vice Chancellor, sir, this has been my story. Thank you, everyone.